Hi dear medicos, myself Dr.Krishneswari and our channel is back. So we were discussing about weakness and paralysis in our last session, is it not? We have discussed about the basic anatomy and physiology of nervous system, about weakness, then some of the words which will be misunderstood for weakness, and also we were well versed about the upper motor neuron lesion and lower motor neuron lesion, is it not? So today in this last session of weakness and paralysis, we are going to discuss about some other types of weakness so that it will be easy for you to understand what is the type of weakness patient presents and also what are the investigations you need to give to that particular patient. Okay, so we will directly go to other types of weakness today. So first important type of weakness other than this upper motor neuron lesion and lower motor neuron lesion is concerned with muscle. Okay, that is concerned with brain and nervous system. Today the first weakness we are going to speak is about the myopathic weakness, which is concerned with the muscles. Okay, myopathic weakness. Myopathic weakness. Okay, and this myopathic weakness, you listen carefully, it is divided into two. Okay, first one is defect in the muscle fibers. Defect in muscle fibers, that is the muscle itself, defect in muscle fibers, and second is defect in neuromuscular junction. Neuromuscular junction. You know about neuromuscular junction very well, you know about synapse, is it not? You know about motor unit, so it will be very easy for you to understand regarding the. So this myopathic weakness, it is divided into weakness due to muscle fibers and also weakness due to neuromuscular junction. And this weakness due to muscle fibers, it is again divided into two. Okay, again divided into two. One is weakness due to reduction in number of muscle fibers. Okay, reduction in number of muscle fibers, and second is reduction in contractile capacity of muscle fibers. You understand? Muscle fiber weakness, weakness due to muscle fibers, it is divided into two. One is due to reduction in number of muscle fibers and second is reduction in contractile capacity. You understand? So first we will see about reduction in number of muscle fibers. So I will be saying the investigations along with this, then it will be very easy to understand. So you know what is the investigation to do? It is electromyography. EMG, electromyography is the investigation to be done in case of myopathic weakness. So in electromyography, what we can see in case of reduced number of muscle fibers. So in reduced number of muscle fibers, what happens is the contractile, the action potential produced by this action potential produced by the muscle fibers will be reduced. You understand? In electromyography, the action potential produced by the number of muscle fibers is reduced since there is reduction in number of muscle fibers. You understand? Then in case of reduced contractility, what happens is action potential will be normal. Action potential will be normal, but the rate of contraction and the speed of contraction will be reduced. You understand? Rate of contraction is reduced. Rate and speed of contraction is reduced. This is how you differentiate weakness due to reduction in number of muscle fibers and weakness due to reduced contractile capacity. In reduction of number of muscle fibers, what happens is the action potential itself is reduced due to the reduction in number of muscle fibers, and in case of reduced contractile capacity, what happens is action potential will be normal but the speed and rate of contraction will be reduced. Okay, you understand. Okay, so this is regarding the weakness due to defect in muscle fibers. Then is weakness due to defect in the neuromuscular junction. So, in neuromuscular junction, what we will be observing is, it is mostly seen in diseases such as, you know about that, right? Autoimmune disease of neuromuscular junction is myasthenia gravis. Right? So, myasthenia gravis. So, this neuromuscular junction defect is mostly seen in myasthenia, diseases of neuromuscular junction such as myasthenia gravis. And here what we will be seeing is there will be increased fatigability. So you remember, increased fatigability. I have discussed in the previous session. If you are having doubt, please go through the previous session. So what we will be doing, what we will be seeing is there will be increased fatigability in electromyographic studies. You understand? So this is about the myopathic weakness. Myopathic weakness is also very, very important. It is mostly seen in our clinical settings. Okay, you understand? This is one of the important weakness, which other than upper motor neuron weakness and lower motor neuron weakness. Then second, we are going to discuss about another weakness, which is hemiparesis. We know about hemiplegia. We know about hemiplegia, which is in upper motor neuron lesion and lower motor neuron lesion. So the last thing what we are not last thing, the next thing what we are going to see is hemiparesis. So we were discussing about paresis. Paresis is a type of mild or moderate weakness. So next is what we are going to discuss is hemiparesis. You understand? Okay. So in hemiparesis affects the what? One side of the body. Is it not? So this hemiparesis, what we have to observe is whether there is any CNS symptoms. So if the lesion is in the brain, if the mostly in hemiparesis the lesion is seen above the foramen magnum, above the lesion is in the above the foramen magnum, that is above the upper section of the cervical spinal cord. Above the upper section of the cervical spinal cord, foramen magnum. What is foramen magnum? Foramen magnum is the largest opening in the skull, through which the spinal cord passes downwards. So this hemiparesis, the lesion will be above the foramen magnum, that is above the upper cervical section of the spinal cord. So if the it is in the brain itself, if it is in the brain itself, then there it is associated with cognitive disturbance. That is, functions of the brain will also be affected. So there will be defect in cognition, there will be defect in language, there will be apraxia, and also sometimes there will be defect in sensations. You understand? If the hemiparesis and the lesion is in the brain. You understand? Second, if there is pure motor hemiparesis without any defect in the functions of the brain, that is without any defect in the cognitive function, if there is only pure motor hemiparesis, then the lesion will be in the posterior limb of internal capsule. Posterior limb of, mostly the lesion will be in the posterior limb of internal capsule or in the cerebral peduncle. You understand? Or in the cerebral peduncle, which is mostly concerned with the motor area, motor functions of the brain. So if it is associated with other cognitive disturbance, then the lesion will be in the brain. If the hemiparesis is purely motor, there is no other cognitive disturbance or sensory disturbance, then the lesion will be in the posterior limb of internal capsule or in the cerebral peduncle. Okay. Then third, there is something known as crossed hemiparesis. Crossed hemiparesis. So what is crossed hemiparesis? Crossed hemiparesis means there will be defect in ipsilateral cranial nerve function. Be very careful. Crossed hemiparesis means there will be defect in ipsilateral cranial nerve function and contralateral hemiparesis. So the defect in Cranial nerves will be in the same side and the hemiparesis will be in the opposite side. Then the lesion will be in the, if the patient is presenting with crossed hemiparesis, then the lesion will be in the brain stem. Okay, then the lesion will be in the brain stem. You understand? Next, fourth, there is something known as Brown-Séquard syndrome. Is it not? Brown-Séquard syndrome. So, if the lesion is in the upper part of the spinal cord, hemisection of spinal cord, it is known as lesion of hemisection of spinal cord is known as Brown-Séquard syndrome. Here, what the patient presents is, there will be ipsilateral proprioceptive defects. Ipsilateral proprioceptive defects and contralateral defect in the pain. Contralateral defect in pain sensation. Ipsilateral proprioception and contralateral defect in the pain sensation, and also along with pain there will be defect in temperature also. So contralateral pain and temperature and ipsilateral proprioception. This is known as Brown-Séquard syndrome. You understand? There is no doubt. If you are having any doubts, you can ask me through the comment box. Okay. So these are the most important varieties of hemiparesis. What we should keep, if a person is complaining of mild or moderate weakness in one side of the body, you should be asking the patient, or you should be examining the patient for all these reasons. You understand? Okay, then we will see what is the cause of acute hemiparesis. Acute hemiparesis, the very most important cause is CVA. Yes, it is ischemic or hemorrhagic stroke. CVA. We will be discussing about CVA in coming sessions. So, acute hemiparesis, the most important cause is ischemic or hemorrhagic stroke or CVA, and sometimes it is also seen in diseases such as multiple sclerosis. Okay, diseases such as multiple sclerosis. If the hemiparesis is subacute, subacute means it evolves over days or weeks. Okay, it evolves over days or weeks. Then the most important thing is what? Hematoma. Okay, the most important thing is hematoma, which is subdural hematoma, and it is also seen in infectious diseases such as HIV infection. It is seen in AIDS. Okay, HIV infection, and also sometimes it is seen in multiple sclerosis and tumor. Subacute. Okay, acute means these are the most important causes. Subacute means it is evolving over days or weeks, and it is usually seen in subdural hematoma or infectious diseases like AIDS and also multiple sclerosis and also tumor. Then if the hemiparesis is chronic, that is evolving over weeks or years, weeks or months, not years, weeks or months. If it is evolving over weeks or months, the most important cause is chronic subdural hematoma. Okay, chronic subdural hematoma, and also demyelinating and degenerating diseases. Multiple sclerosis like condition, demyelinating and degenerating diseases of the nervous system. You understand? So these are the most important things which is in concern with the hemiparesis. You don't go to weakness of one side. You just ask the patient whether there is any defect in language. You just observe the patient. You do the mini-mental. You don't do the full examination. You just do the mini-mental state examination. You just ask for language. Then you do the examination for language. Then you can diagnose it without any investigation. You understand? These are the symptoms which will be in concern with the hemiparesis, and from this itself you can reach a provisional diagnosis where the lesion is within the central nervous system or spinal cord or anything. You understand? Okay. Then third is we are going to discuss about monoparesis. So we have discussed about what? Myopathic weakness, that is weakness due to muscle involvement. Then we have discussed about hemiparesis, which affects one side of the body. Then we are going to discuss about the monoparesis. Monoparesis means it is seen in lower motor neuron disease. Monoparesis, lower motor neuron disease. Okay. Upper motor neuron lesion and lower motor neuron lesion or weakness is different from that of upper motor neuron disease and lower motor neuron disease. Please, you don't get confused with that. Okay, we will be discussing this lower motor neuron disease and upper motor neuron disease in the coming sessions. So, monoparesis, it is seen in lower motor neuron disease. It is something concerned with lower motor neuron. You all know about upper motor neuron and lower, is it not? So, this is something concerned with lower motor neuron, and this monoparesis, it is seen in lower motor neuron disease. Next is paraparesis. Para means two limbs. Mostly this paraparesis, it is seen, it will be affecting the lower limbs, and it is seen if the lesion, paraparesis is seen if the lesion is below the upper thoracic spinal cord. Okay, if the lesion is below the upper thoracic spinal cord, then it results in paraparesis. So, the most important lesion in connection with this paraparesis in spinal cord is slowly evolving conditions such as, that is which is what we can say, which is compressing this spinal cord, or the nerves which are coming out of the spinal cord. So, lesions such as tumor, abscess, and also very important, intervertebral disc herniation, very important. Okay, so this intervertebral disc herniation may also lead to paraparesis. You should be very careful while treating a case of intervertebral disc herniation. You should be very careful in assessing the symptoms of disc herniation. Okay, it may result in paraparesis. You be very careful. Okay, so tumor, abscess and intervertebral disc herniation, and very rarely, if there is something in the cerebrum, it is very rare. Okay, if there is something in the cerebrum, there is chance of paraparesis. It is very rare, and also there is something known as Corda equina syndrome. Corda equina syndrome, you know about that. When there is compression in the corda equina of the spinal cord, it may result in paraparesis. You understand? So, now we are thorough with myopathic weakness, hemiparesis, monoparesis and paraparesis. Next thing is quadriparesis. Quadri means all the four limbs will be affected, and this quadriparesis, it is also known as generalized weakness. Okay, so this, you should be very careful with this quadriparesis. So, we should understand if the quadriparesis is due to something related to brain. If it is related with the CNS, then there will be change in the, as we told earlier, there will be change in the cognitive function. So, in quadriparesis, it is also known as generalized weakness. It is not the term which is used for weakness. We have discussed what is weakness. So, you take the term in that sense only. Weakness, reduced power of the muscles, what we are saying. So, generalized power will be reduced, that is of the four limbs it will be affecting. So, in case of quadriparesis, if it is in connection with CNS, there will be cognitive function affection. So, if it is in relation with the neuromuscular junction, neuromuscular junction weakness or neuromuscular junction defect also leads to generalized weakness or quadriparesis. So, if it is in relation to neuromuscular junction, then there will be no cognitive function affection. Okay, there will be no cognitive function affection. And also the most important thing is, when a patient presents with this quadriparesis means reduced, mild or moderate weakness, you should go for the electrolyte disturbance of the patient. You should check the electrolyte balance or electrolyte normal. You should check for the serum electrolytes in that particular patient. When there is some electrolyte disturbance, it also leads to quadriparesis. You understand? So these are the most important type of weakness we should differentiate when a patient presents with weakness in front of you. Okay. Then there is something known as, you understand this? Okay. Okay. Then there is something known as distal weakness and proximal weakness. Distal weakness and proximal weakness. So what is distal weakness? Distal weakness means in most, in both the extremities, upper and lower extremities, distal part weakness will be there. There is no defect within the girdle muscles. Apart from the girdle muscles, distal weakness will be there. And in case of distal weakness, you should be very careful. It may be due to lower motor neuron disease. Lower motor neuron disease, or the very important things what we will miss is peripheral neuropathy. So there are so many causes of peripheral neuropathy, which is also a symptom of CNS. We will be discussing later. And this distal, if a patient presents with distal weakness, then it may be due to lower motor neuron disease or peripheral neuropathy. And if the patient is presenting with proximal weakness, proximal means both the girdle muscles will be affected, shoulder girdle and hip girdle muscles, proximal, shoulder girdle and hip girdle will be affected. So if there is defect with in this proximal weakness, proximal muscles, or if there is proximal weakness, then it is mainly due to myopathy, myasthenia gravis or something related to myopathy. So there is nothing to do with this peripheral neuropathy in proximal weakness, and it is due to myopathy. So peripheral neuropathy, it is a most important condition. Most of the patients in diabetes, thyroid, etc. will be presenting in front of us. If he is saying that there is distal weakness, then you should go for peripheral neuropathy also. So these are the most important things you should keep in mind while dealing with a patient with weakness. So we have discussed about the different types of weakness. Now it is very easy for you to know about the investigation. Just I will say some of the investigation or evaluation. How will you evaluate a patient with weakness? So when a person complained of weakness, you go to the history of the every time. As I say, history taking. It is very important as far as a diagnosis, or as far as a investigation, or as far as homeopathy is concerned. So you go for the history of the patient. Okay, so history of the patient. From the history, you can diagnose whether it is plegia or paralysis, or it is simply weakness, it is monoparesis or hemiparesis. All the type of weakness you can differentiate from the history. From the history, you can go to the investigations. Is it not? So the most important thing what you should do is, as far as this paralysis and plegia is concerned, you go for the MRI and CT brain. So we can see the brain, or we can guess the brain through the CT and MRI. MRI, we can know more about the soft tissues in the brain. You go for MRI spinal cord, you can see, is it not? If there is disc or tumor or abscess, you can see in case of MRI spinal cord. Then what you should do? You can go for electromyography if there is anything concerned with muscle fibers. Then you can go for nerve conduction studies. If there is something, if you are suspecting something defect with the nerves, you can go for nerve conduction studies. And also you don't forget the most important thing you should do in case of weakness is electrolyte disturbance. Also you go for serum electrolytes, you go for thyroid level, you go for diabetes mellitus. So this blood sugar. So these are the most important investigations which revolve around the weakness and paralysis. So if you are understanding what type of weakness and paralysis is this, or if you are understanding, okay, what is this? This is then suddenly you will be thinking, this weakness, so the lesion will be there. Like that you can diagnose by this session, is it not? So you go for the particular investigation. You understand? So by this we are concluding weakness and paralysis. I hope that this session is very useful to you. If it is useful and if you are happy with the session, please, again the same thing, please subscribe, share to your friends. Happy learning. Next time, in the next session, we'll be meeting with another symptom of neurology. Thank you so much.